PSA test and you have a value that indicates to you that there's a possibility of cancer, okay, before you go to treatment, you would do something like a biopsy. How does that fit into all this?
You would never treat without a biopsy. You need confirmation there's cancer there before you would treat it.
Okay.
So if you have an abnormality in the PSA or the digital rectal exam, you would go ahead and do the biopsy. If it's negative, great. It doesn't mean it doesn't necessarily mean there's not cancer there, but it just means you didn't find the cancer. The biopsy is literally a random sampling of the prostate. So you're taking 12 tiny little samples of the prostate, millimeters in length, and you're taking 6 on the left, 6 on the right, random sampling. You can't see the prostate cancer. You're not aiming for cancer. You're just looking at the prostate. And if it comes back negative, good, but you may have just missed where the cancer was or a section of the cancer. But if it comes up positive, then you know there's something there. Could there be more cancer right next to that, or higher grade cancer right to the left or to the right? Absolutely. So it just gives you a real small window into the prostate. But you need a diagnosis before you treat. No one would ever treat prior to having a biopsy diagnosis.
I guess what I'm trying to understand is as I understood it, you treated 5 people, but you were only able to save 1. And you treated them based on the PSA and then the biopsy.
Mm-hmm.
Okay, but they're saying that there's over-treatment and over-detection. So how does the biopsy fit in with the PSA saying one thing and then something further with the biopsy? Am I making sense?
Say it one more time.
As I understood it, that they're saying that if you do the PSA test, it leads to over-detection and over-treatment. Is that correct?
Correct.
Okay.
That's one of the cons for screening cancer.
Right, but in between the PSA test and the treatment is the biopsy test.
Right.
So I guess I don't understand, if you go and do the biopsy and you don't do treatment, if you have a negative on the biopsy,
Right.
why would you have over-treatment?
If you don't go ahead and treat,
Right, you have a negative biopsy.
right.
So there's no reason to do a treatment.
Correct.
What they're saying is that the amount of patients being treated goes up. It doesn't mean they're being treated overly and shouldn't be. It means more people are treated that should be treated because they've been diagnosed with cancer. But they don't live any longer. They die at the same rate as if everybody had walked away from it at the very beginning because they didn't have a PSA test. So there's 5 of those that get the treatment because they have cancer. The biopsy said they do. But they don't live any longer than if they had.
Right.
But one person does.
Right, okay. I see.
So of the 5 you
Yeah.
treat,
So 5 don't.
1 actually lives longer because of the treatment.
It makes a difference. You actually are affecting their longevity
Okay.
versus it's not affecting the longevity of others. And that's just a statistical term and that goes for any treatment you do for any cancer. There's some number needed to treat for any, whether it's
This
breast
is-
cancer, colon cancer.
This is really being driven by how long it takes this cancer to kill you.
Oh, it's a huge problem.
Yeah, I mean, that's really what you're pointing out, is they cut it off, the study off early.
That's a
and you-
major factor
you know,
of studying prostate cancer.
The
because
leverage on this is
It takes so
especially for
long.
younger men,
Yeah.
45 years old.
It takes so long to study this that you have to wait 10, 20 years to
But you
know
can
whether
save the last 20 years of their lives if they're detected at 45 or 50.
if they're young and can live 10 years. And
Yeah.
that's what this data is showing. Yeah.
Does cancer location affect PSA value? Because I know the case like, location there is difficult, even you use hand to touch it, you
Mhm.
cannot find it.
Location in the prostate?
Yeah.
Not that I'm aware of. Yeah. Typically, prostate cancer is located on the outside of the periphery of the prostate, sort of on the outside of the prostate, which is why when we do the rectal exam, that's what we would be feeling. It's not usually on the inner part of the prostate.
Do you have cases in the part of?
Yeah, I mean, you'll see them, and it's
Or
not.
PSA can.
It's not like it's
can
unheard
feel-
of, but the PSA is, I don't know of any data that says PSA is affected by where the prostate cancer is in the prostate. I don't know of anything that says that. All right, where were we? So this is just a schematic of showing the reanalysis. If you remove the sick patients, what would the data look like? And the top graph shows if you remove patients with multiple morbidities, you actually do see a difference of death rate among screened and non-screened patients, versus the bottom one, you don't see a difference.
But still quite a few years out.
But still, yeah, again,
Not bad, but
you're not really seeing anything. Now, this kind of separate maybe around the 6, 7, 8-year data, but still in that same range. Yeah, you're not going to see anything within 7 years. It's just not going to happen. Well, 8 or 9 years. The third lesser-known study, this is sort of the ugly stepchild of the three, but the Göteborg study, and unfortunately, because this is actually the one that had some of the that basically was the best study of all three. Only 20,000 men is it's still a lot of people, but compared to the others, it's much less. 14-year follow-up. Like I said, regarded as probably the best of the three trials. Only 3% contamination rate. So compare that to the 50-something% in the American trial. They came out with 44% reduction in prostate cancer mortality, eerily similar to this one. 44% if you remove the unhealthy patients. Their number needed to screen, 293, number needed to treat was 12. Again, I threw the breast cancer in there as comparison to remind us. Unfortunately, this had very little press. We are seeing similar numbers around the world. In Europe, with their healthcare system, they are able to track things a lot better than we are. So they're seeing similar trends in countries that do screen versus do not screen. Tyrol, Austria. There's a city in Austria that was the only city in Austria offering free prostate cancer screening, free PSA screening. And what they showed was a 54% reduction in prostate cancer deaths in Tyrol versus 29% in the rest of Austria. So it wasn't a randomized control study, so not as quality as the other ones, but still interesting. In Northern Ireland, very few people are screened, only 6%. They compared that to the ERSPC trial, where there was a 30% reduction, 30% lower prostate cancer survival in the Northern Ireland population. So, like I said, the controversy still remains. They're still fighting back and forth on both sides of it. There are 2 further studies that are hopefully coming out. Maybe that will solve everything, but more likely than not, it will give us more questions than answers, but we're hoping. So, guidelines, they are sort of range all over the place, from the new preventive task force guidelines that say don't do it, to ironically enough, the Japanese Urologic Association, which are one of the more aggressive ones that we talked about, even though they have one of the least prevalence in the world. But they range everywhere. The AUA, they recommend starting at age 40, at least with a baseline. Some of them determine what your risk factor is, that's how often you should do it. This is the most recent AUA update, best practice series from 2009. I think they're going to be coming out with one this year, I believe, because of all the controversy. They want to get another one coming out. But basically, baseline at age 40. You don't want to just react to one PSA. This really should be a thoughtful approach. You want to use it wisely. No single threshold of PSA like we talked about. You want to look at the PSA and the digital rectal exam, but you want to ask yourself all the other things as well. How old is this person? How healthy is this person? Am I going to be, if I have a 75-year-old gentleman who's got no medical problems, everybody in his family has lived to 110, he runs marathons, I probably would still screen him. If I have a 60-year-old gentleman who nobody in his family has lived over 61, he's had 5 heart attacks, and he's got diabetes, high blood pressure, you can make an argument not screening that person, because the likelihood of them living another 10 years probably is not going to happen. So you have to use your brain. You can't just sort of make a blanket statement.
more like triage.
It's very, that's part of what we do.
Yeah.
Family history, again, is very important. And again, a lot of these things aren't incorporated into the task force recommendations. Screening can lead to overdetection, overdiagnosis, like we talked about. The big thing they're talking about these days is just informed consent, decision-making, have the patient share in the decision-making process. You will see that over and over and over again.